Welcome, Professor Ali.
Okay, thank you very much for the introduction, and thank you very much, Professor Azza, for this kind of invitation. So today I'll talk about ERCP, mastering the technique. This is not moving, huh? Okay, now. Over the next 10 minutes, hopefully I'll try to cover a very important aspect of ERCP, which is a cannulation technique. There's a lot of aspect in ERCP, so it's very difficult to cover everything, but hopefully I want to cover the most important step in ERCP. So we know ERCP is a very complex procedure that requires a lot of skills from both the endoscopist and the assistant. And we know the very first step of ERCP and the very difficult step is cannulation, but we know without cannulation we cannot perform any therapeutic interventions. So let's just talk about the basic cannulation technique, and this is very important. If you have a good cannulation technique, basic understanding, you'll be able to achieve basic or cannulation in the majority of cases. So the first step is try to spend time to achieve proper position, usually in the short position. So this allows you to have a stable position in the second part of the duodenum, have a good visualization of the major papilla. Keep it in mind that certain cases you need to go with the long position, semi-long position, but the bottom line, try to achieve a stable position before you try to cannulate. The next step is trying to inspect the papilla. So as you can see, the papilla is not simply a small protrusion with a tiny hole in it, but rather there are other aspects to it, such as the suprapapillary folds. There are a lot of structures in the papilla that are important to visualize and understand before trying to embark on cannulation. In addition, choosing the right accessory is important, and we'll talk about the different sphincterotomes and cannulas and when to choose which based on the anatomy. And once and only once you have basic understanding of the papilla, then you try to cannulate. So this is where you engage the papilla with the sphincterotome, for example, very gently, and then try to align your accessory in the direction of the duct with very small fine movement. And we always say try to aim for the 11 o'clock position if we're aiming for the bile duct, and the 1 o'clock position for the pancreatic duct. And finally, we'll talk about the difference between guide wire technique versus contrast. The very important message is never fight the papilla. So whenever you try to cannulate the bile duct, be gentle. I see a lot of people trying to cannulate with force using their sphincterotome, using the wire. This will only just cause a lot of trauma, some edema, and you will unlikely to succeed. So when we talk about cannulation, we always talk about the different accessories, including different sphincterotomes, catheters. They come in different shapes and sizes. Different companies have different sphincterotomes. The bottom line, for the vast majority of cases, just use the sphincterotome you're comfortable with, but in certain cases you have to use specific sphincterotomes, specific accessories. For example, in small papilla, it might be better to use a minitome, for example. Same thing applies to guide wires. They come in different shapes and sizes. They can be straight wire, it can be a straight trip, it can be angulated. This is very important. So whenever you see the ampulla, try to classify it into those four categories. Type 1 is the most common, the regular papilla that we see most commonly, and luckily it's the easiest to cannulate. Type 2, which is here, this is the small papilla. This is very difficult to cannulate. It is associated with higher risk of post-ERCP pancreatitis, and it is an example where probably you should start with a minitome or with the wire first to achieve biliary cannulation. Type 3 is also another challenging papilla. This is the kind of redundant folds, very floppy papilla that you have to be very gentle when you try to cannulate it, otherwise you're just creating a lot of false tracks. And again, the cannulation rate or the difficult cannulation rate here is much higher compared to type 1. And finally, type 4, the least common, the ridge papilla, and the cannulation success or failure, I should say, is kind of in between. Remember, abnormal papilla can be challenging. Ampullary edema, as seen in acute pancreatitis, ampullary cancer, peri-ampullary diverticulum. These are all challenging cases that you have to take into consideration when you're trying to cannulate. This is just a quick video. This is the basic cannulation technique. This is a type 1 ampulla. We're trying to cannulate using a sphincterotome with the wire. We're aiming at the 11 o'clock position, engaging the papilla very gently with a little bit of movement of the scope with a small wheel. We're able to achieve deep biliary cannulation, and we confirm it by advancing the wire and injecting contrast. So we talked about contrast-guided cannulation, wire-guided cannulation. With contrast-guided cannulation, you're just impacting the catheter into the papilla and injecting contrast to give you a roadmap where you want to head. The problem with this technique, you might cause increase the risk of post-ERCP pancreatitis because of inadvertent pancreatography, and that's why we're using more of a wire-guided technique where you're using the wire to guide you into the desired duct. And in fact, there have been multiple studies which compare the two techniques, and it's very, very clear now that guide wire technique is superior to contrast-guided cannulation when it comes to cannulation success, as well as the rate of post-ERCP pancreatitis, which is significantly lower, and there's less need for pre-cut sphincterotomy when we use wire-guided, and therefore all the guidelines suggest that wire-guided cannulation should be preferred. So this is the basic technique, but in certain cases we may encounter difficult cannulation, which is defined by the ESGE as cannulation time more than 5 minutes or more than 5 attempts to cannulate, or if you enter the pancreatic duct more than once. In this scenario, you have several options. Either you persist with the same technique, trying to cannulate using sphincterotomes or the cannula. I don't recommend this technique because it's unlikely to succeed, and you're just increasing the risk of post-ERCP pancreatitis. What we recommend, either going to an advanced cannulation technique, which I'll discuss next, and sometimes it's okay just to stop the procedure, especially if the patient is stable, and just repeat after 48 hours with another endoscopist or with yourself. So these are the techniques I'll discuss very quickly now. The first technique of the advanced cannulation technique is the double guide wire technique. This is probably the most commonly used and most well-studied technique, where you have a wire in the pancreatic duct and you leave it there, and it serves the purpose of blocking the pancreatic duct as well as straightening the duct, so you're able to achieve biliary cannulation using a second wire. And multiple studies suggest that this technique works very well, but this is the major problem of this technique, and in fact it's the major problem with any cannulation technique that involves the pancreatic duct cannulation, which is post-ERCP pancreatitis. So remember, always leave a pancreatic duct stent there. Other techniques that involves the pancreatic duct include inserting a pancreatic duct stent and then trying to cannulate over it, such as this case here. Can tell you it's very difficult to achieve biliary cannulation once you have a pancreatic duct stent. The other technique is, once you leave a stent, you just perform a pre-cut sphincterotomy over the pancreatic stent. I just want to talk about transpancreatic septotomy. So this technique has been described 30 years ago, getting more traction recently, and it is actually what we do. We leave the sphincterotome in the pancreatic duct, and then we cut toward the 11 o'clock position. So we're aiming toward the bile duct, with the hope we're cutting the septum between the CBD and the PD. I can tell you, based on the current studies, this is a highly effective technique. We always worry about the complication of post-ERCP pancreatitis with this technique, but the risk is actually is not much higher than other techniques. It's about 5 to 10% as long as you leave a pancreatic duct stent. The other technique, which we well know, is the needle knife pre-cut, including needle knife cut sphincterotomy, where you start from the ampulla and then you cut up, or needle knife fistulotomy, where you, as you can see in this example here, you cut away from the ampullary orifice. So this is a highly effective technique, but it requires a lot of skills. If you don't do it properly, you increase the risk of complications, serious complications, including bleeding, including perforation. And if you don't do it early, you're increasing the risk of post-ERCP pancreatitis. So the important question is, which of these advanced techniques is the best? So believe it or not, transpancreatic septotomy is the best technique based on the current evidence when it comes to cannulation. And not only is the best technique, but also it is the safest technique when it comes to post-ERCP pancreatitis risk, along with early needle knife sphincterotomy. So this is something maybe we can discuss later, which is which technique you use, but in fact this has the best evidence. So this is just a study we tried to do, and to kind of answer the question is how soon or how long should you wait before you perform a pre-cut sphincterotomy, because this is still an unanswered question. So we did this study which involved 140 patients. There are some issues with the recruitment, but we divided the patient to primary pre-cut, early pre-cut, where we performed pre-cut after 2 minutes of trying, or standard pre-cut. We waited at least 5 minutes before we perform a pre-cut. It was very clear that the sooner you do the pre-cut, the lower the risk of post-ERCP pancreatitis. Now, I'm not saying that you should do primary pre-cut, but I'm saying don't wait for too long if you're struggling with cannulation, and try to do pre-cut early on. Don't wait for too long, otherwise you just increase in the risk of post-ERCP pancreatitis. So this is this approach as suggested by the ESGE when it comes to biliary cannulation. So they suggest that try to cannulate the biliary tree. If you fail within 5 minutes, just move on. Don't continue the same strategy. Just move on to the next technique, which is utilizing a advanced technique. And it depends whether you have access to the pancreatic duct or you don't. So if you have access to the pancreatic duct, you have several options. They do recommend double guide wire technique, but if you fail, you can use transpancreatic septotomy. And as I mentioned, now you have more evidence to suggest this is a highly effective technique, or you can use a needle knife over the pancreatic duct stent. If you don't have access to the pancreatic duct, then really your only option is needle knife sphincterotomy or needle knife fistulotomy. And always keep in mind that it's okay to stop the procedure and repeat it after 48 hours if you fail. So this is just my last slide. In conclusion, ERCP is a highly demanding procedure that requires a lot of skills, but having basic cannulation technique, adequate basic cannulation technique will ensure achieving biliary cannulation in the vast majority of cases. Remember to use advanced techniques early on, and don't wait too long. With this, I'll conclude my presentation, and thank you very much for your attention.
Professor, I thank you very much for your presentation, but I have just only a comment. To master the ERCP, it's not only the cannulation. You have to return back what's your actual target that you are looking doing ERCP. Drainage of the biliary system is mastering the technique, taking the proper decision. If you fail, you have another options with a multidisciplinary team, either the interventional radiologist or even the surgery. So it's good presentation about the difficult cannulation and how can you overcome. But I would like just to express it's not only the way to master the ERCP, and that's it. Thank you.
I absolutely agree with you. There are a lot of things to master in ERCP, and cannulation is just one of them. But as you mentioned, even removing stones, complex stones, big stones, what to do with them, stenting, and as you mentioned, even sometimes when we fail, just kind of think of what should be the next step, which is not necessarily just ERCP. As you mentioned, there are other options. I absolutely agree with you. Yeah.
Okay. Any question from the floor, chairperson? Comment.
One important point from the lectures also to understand the anatomy for choosing the options of mastering after failure or difficult ERCP, the types of papilla, also choose which one of the advanced technique. I think ESG guidelines algorithm is very important to be in your mind. Thank you for.
Thanks.
Transpancreatic technique, sphincterotomy. When you enter pancreatic duct, you prefer to do from the start or do double wire technique?
So this is a very good question, honestly. So what I used to do, and this is what they suggested by the ESG guidelines, if I'm inside the pancreatic duct, I try to do the double guide wire technique. If it fails, I used to spend a little bit more time trying to cannulate and go to the biliary tree, and then maybe do a pre-cut. But more recently, I was trying the pre-cut transpancreatic septotomy early, and honestly, it works very, very well. It works really well. Now I have a much lower threshold to do transpancreatic septotomy, and now if you ask me, I prefer it over pre-cut sphincterotomy if I have access to the pancreatic duct. I still give it a try with the double guide wire technique, but I don't spend a lot of time. I try for 1 or 2 minutes, it doesn't work. I just move quickly to transpancreatic septotomy, always making sure that I place a pancreatic duct at the end, and I can tell you it works really well, surprisingly well, that I have now much lower threshold just to do it. But I don't do it first. I try the double guide wire technique for a couple of minutes. Doesn't work, I move to the transpancreatic septotomy.
If you do transpancreatic sphincterotomy, better to insert pancreatic stent or not?
Always. So whenever I go to the pancreas with the wire, whether I'm using double guide wire technique, whether I'm doing a transpancreatic septotomy, always I'll leave a pancreatic duct stent, always. Because we know the risk of post-ERCP pancreatitis is higher. Whenever you touch the pancreas, I always leave a pancreatic stent.
Thank you.
Thank you.